Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today we're tackling a really critical topic, the established protocols for managing ruptured abdominal aortic aneurysm, or rAA. It's a true vascular emergency, isn't it? Our discussion draws heavily on UK best practices. Think NICE and VSGBI guidelines. They're all about that rapid, coordinated response.
Absolutely. And the urgency is stark. Pre-hospital mortality rates are shocking, upwards of 80%. Survival literally hangs on how quickly and smoothly the hospital team responds. It has to be protocol-driven.
Units count. There's no room for error. And just to be clear for everyone listening, this content is presented by the Surgical Edge podcast.
Yes, and it's crucial we add this disclaimer. It is vital to remember that this content is for reference only, and all clinicians must follow local guidelines in clinical practice. Always your local protocols first. So our aim today is really to unpack the practical steps, from that first inkling of suspicion right through to the definitive fix.
Okay, let's dive right in. Section 1, the art of suspicion. This is where it starts, and honestly, it can be really tricky. We're often taught that classic triad.
Right, the hypotension, the back or abdominal pain, and feeling that pulsatile mass.
Exactly, but the sources are clear that full triad, it's only present in about, 50% of patients?
That's the classic trap, yeah, only about half. That's why you need such a high index of suspicion, especially in older men, maybe with known cardiovascular risks. rAA has got to be on your radar.
And the typical pain description itself should be a huge warning sign, shouldn't it? Sudden, really severe, constant pain, abdomen, loin, back, often shooting down into the groin or buttocks.
Definitely. And if the patient knows they have AAA already, that elevates suspicion massively.
But then you get the atypical presentations, the ones that throw you off.
Oh, absolutely. Those are the diagnostic nightmares, like the contained rupture, the so-called Herald bleed.
Yes, where they might have a syncopal episode or bad pain that seem to stabilize for a bit.
Exactly, that lucid interval. It happens because the retroperitoneum forms a temporary tamponade, holds the bleeding back for a short while.
A really dangerous stability, though. It can lead to delays before the inevitable catastrophic re-rupture.
Precisely. And then you've got the fistulas creating confusion. An aortoenteric fistula that looks like a major GI bleed hematemesis melena completely points you in the wrong direction initially.
And the other one, the aortocaval fistula. Less common, but presents almost like heart failure.
Yeah, high output cardiac failure signs, maybe that classic machinery murmur, distended veins in the legs. Very misleading.
So when you look at all these possibilities, it's easy to see how rAA gets mistaken for other things. Renal colic, diverticulitis, pancreatitis, even an MI. Aggressive suspicion is key. Okay, so suspicion is high. Now what? We move into this phase you call the parallel process of resuscitation and diagnosis simultaneously.
Yes, simultaneous action is crucial. The aim is theater in minutes, not hours, minutes.
And this is where resuscitation gets different from standard trauma, right? Because of the contained bleed.
Exactly. How do you resuscitate without blowing the clot? The cornerstone strategy is permissive hypotension.
Right. This is maybe the most vital takeaway. We're not just pouring fluids in. Why? Explain that again.
Because flooding the patient with crystalloids or pushing the blood pressure up too high can easily disrupt that fragile retroperitoneal tamponade. You make the bleeding worse, potentially catastrophically worse.
So the idea is just enough pressure to keep vital organs ticking over.
Precisely. The target systolic blood pressure, the SBP, is usually between 80 and 100 millimole Hg. That gives you just enough flow for the brain and the heart, minimal perfusion.
So not too high, not too low. Find that sweet spot.
You got it. And the second resuscitation starts, you hit the button on the major hemorrhage protocol, MHP activation, instantly.
Get the big IV lines in.
Yep. Ideally 2 14-gauge cannulas. But honestly, in that emergency setting, get whatever large access you can quickly. Proximal lines if needed, just get access.
And the blood products, what's the target ratio?
Right. We're aiming straight away for that 1.1.1 ratio. Packed red cells, FFP, and platelets. It's not just about volume. These patients often have a profound coagulopathy from the shock, the cold, the dilution. This is damage control resuscitation.
And tranexamic acid.
Absolutely. 1 gram IV as soon as you possibly can. Standard part of the MHP now.
Okay, so MHP is running. Diagnosis needs to happen now. Not fancy imaging, though.
No, not initially if they're unstable. The primary tool is the bedside ultrasound, usually a fast scan-focused assessment with sonography for trauma.
Quick, non-invasive.
And critical. If that ultrasound shows an aneurysm, maybe some free fluid, and the patient is clinically unstable, showing signs of rupture, the protocol is crystal clear. Do not delay for a CT scan.
Straight to theater.
Straight to theater. Diagnosis made.
So CT angiography has a really limited role here then. When do you use it?
Only in two main scenarios. The patient who is genuinely hemodynamically stable, or if the diagnosis is really unclear after the initial workup.
And the CT gives you the anatomical detail for EVR suitability, right?
Exactly. It maps everything out for potential endovascular repair. But, and this is a huge but, wheeling an unstable patient to the CT scanner is incredibly risky. That talk and scan idea for borderline cases, you need an extremely low threshold to abort that scan and run to theater if they even flicker.
Right. That makes sense. Which brings us neatly to Section 3, definitive management. And the guidelines have shifted here, haven't they? Towards EVAR first line.
They have, strongly. Nice. VSGBI, they favor endovascular aneurysm repair if it's technically feasible.
And the evidence backs that up.
Yeah, particularly the IMPROVE trial. It showed that for patients who are suitable candidates, EVAR generally means less surgical trauma, less blood loss, better 30-day survival rates, and shorter ICU stays compared to open surgery.
Sounds like a win-win, but obviously not for everyone. What pushes you towards open surgical repair, OSR?
Two main things, really. First, hemodynamic instability. If the patient is too unstable for that prerequisite CT scan, it's OSR by default.
Makes sense. And the second?
Anatomy. Even if stable, the aneurysm's shape, particularly the neck just below the renal arteries, has to be suitable to securely anchor the stent graft. If the anatomy isn't right, or if you don't have a 247 experienced endovascular team and the right kit immediately on hand, OSR is the necessary life-saving choice.
You mentioned EVAR can sometimes be done under local or regional anesthesia too.
Yes, with sedation, that can be an advantage. And crucially, if the patient starts to crash during the EVR procedure, there's the option of aortic balloon occlusion.
Ah, the ABO. Tell us about that safety net.
It's basically an emergency internal clamp. You thread a balloon up via the femoral artery, usually position it above the rupture site, often supracoeliac, and inflate it. It provides immediate proximal control, stops the bleeding temporarily.
Buys time.
Buys critical minutes to stabilize, gain definitive control, or even convert to an open procedure if needed. It's a vital tool in the hybrid OR setting.
Got it. Okay, so let's talk open surgical repair then. Given the instability factor, OSR is still very common for ruptures, isn't it?
It is. Often it's the only option. It's the definitive repair in those unstable or anatomically unsuitable cases. The absolute key step is getting proximal control, fast clamping the aorta, often high up, supracoeliac, to stop the inflow.
And then replacing the damaged section.
Exactly. You replace it with a synthetic tube graft, usually Dacron. It's a major operation, yes, and carries significant physiological stress and higher mortality than elective EVR. But when EVAR isn't an option, OSR is what saves the life.
To help listeners consolidate this complex process, you mentioned the 1-2-3 rule.
Yeah, it's a simple way to think about the organizational readiness required. One consultant needs a vascular surgeon and an experienced anesthetist involved right from the start.
Okay.
2 rights means the hospital must have both open and endovascular capabilities readily available, ideally in a hybrid theater setup.
Makes sense. And 3.
3 key steps: resuscitate with permissive hypotension, diagnose rapidly, usually ultrasound first, and operate immediately. That structure provides the framework.
A clear framework for a chaotic situation. Which leads us to the aftermath. Section 4. Postoperative management and complications. Critical care is a must, right?
Absolutely mandatory. ICU or a high-dependency unit. Every single patient. The physiological hit they've taken is immense.
And the complication that everyone dreads most post-op.
Probably abdominal compartment syndrome, ACS. It's common and deadly.
That's driven by the massive fluid shifts, the hematoma itself, and the reperfusion injury after the clamp comes off.
It's the triad, yes. It creates a vicious cycle of swelling inside the abdomen. You have to monitor intra-abdominal pressure, closely bladder pressures usually. And the threshold for taking the patient back for a decompressive laparotomy, just opening the abdomen to relieve pressure, has to be incredibly low.
Even if the repair seems okay.
Yes. ACS is a clinical diagnosis based on pressure and organ dysfunction. You treat the physiology, not just the scan. Release the pressure.
What about other major risks? Ischemia seems high on the list.
Yeah, very high. Myocardial ischemia is a big one. Remember, these are often patients with significant underlying heart disease pushed to their absolute limit.
And gut ischemia.
Colonic ischemia, yes, especially after open repair where the inferior mesenteric artery might be sacrificed, or just from the prolonged period of low blood pressure. You need to watch lactate levels, look for clinical signs, and have a low threshold for a sigmoidoscopy to check the bowel lining.
And the really awful one, spinal cord ischemia.
Thankfully rare but devastating. Paraplegia, linked to prolonged aortic clamping times or severe prolonged hypotension affecting spinal cord perfusion. And then, of course, kidney injury is common from contrast dye if they had a CT, the hypotension, the aortic clamping. And unique to EVR, the long-term worry is endoleak, where blood leaks back into the aneurysm sac around the graft. That needs lifelong surveillance.
So pulling it all together, managing rAAA really is the ultimate test for vascular service, isn't it? Success boils down to that chain of survival. Prompt suspicion, controlled resuscitation, rapid diagnosis, and getting the patient immediately to a place equipped for both open and endo repair.
Absolutely. It's about the system working seamlessly. And perhaps a final thought, connecting back to those tricky presentations. Think about this. How often does that very strategy of permissive hypotension, which buys us time, actually mask a contained rupture just long enough? It underscores the need for constant vigilance, even when the patient seems stable for a moment. Something for you to mull over.
A sobering thought indeed. If you like this deep dive, do not forget to share it with at least one of your colleagues or friends and spread the word.
Until next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.